today we'll be examining the genital area. I'll be examining.
Your learning objectives for mastering the examination of the male genitalia, hernias, anus, and rectum are to assess the penis for placement of the urethral meatus and any lesions or ulcerations, to assess scrotal contours, noting swellings, edemas, or asymmetry suggesting cryptorchidism, palpate the testis, epididymis, and spermatic cord, identify direct and indirect inguinal or femoral hernias, teach the self-testicular examination to enhance detection of testicular carcinoma. Common concerns relating to the male genitalia and hernias include sexual orientation and sexual response, penile discharge or lesions, scrotal pain, swelling, or lesions, and sexually transmitted infections, STIs, also termed sexually transmitted diseases, STDs. Discussing gender identity and sexual function touches a vital and multifaceted core of your patients' lives. A neutral, non-judgmental approach is critical for ensuring your patient's health and well-being. To put your patient at ease, adopt the following tips. Explain why you are taking the sexual history. Note that you realize this information is highly personal and encourage the patient to be open and direct. Relate that you gather this history from all of your patients. Affirm that your conversation is confidential.
For me to provide the best possible health, I need to take a thorough sexual history to determine if you're at risk for sexually transmitted infections. I know that this is a sensitive topic, but everything you say is confidential and will stay only between us.
Oh, okay, yeah.
Recent surveys suggest that 7% to 8% of men and 4% to 7% of women report they are gay, lesbian, or bisexual. These patients often experience significant anxiety related to being accepted by care providers. By expanding your knowledge and clinical skills about gay, lesbian, and transgender health, you can ensure successful patient care. Before beginning, let's review the important anatomic structures. The shaft of the penis is formed by 3 columns of vascular erectile tissue, the corpus spongiosum, containing the urethra, and 2 corpora cavernosa. The corpus spongiosum forms the bulb of the penis, ending in the cone-shaped glans with its expanded base or corona. The urethra opens into the vertical slit-like urethral meatus, located somewhat ventrally at the tip of the glans. The testes contain interstitial tissue and seminiferous tubules. The scrotum is a loose wrinkled pouch divided into 2 compartments, each of which contains a testis or testicle. Covering the testis, except posteriorly, is the serous membrane of the tunica vaginalis. On the posterolateral surface of each testis is the softer epididymis, consisting of tightly coiled spermatic ducts that provide a reservoir for storage, maturation, and transport of sperm from the testis to the vas deferens. During ejaculation, the cord-like vas deferens transports sperm from the tail of the epididymis to the urethra. Behind the bladder, the vas deferens merges with the seminal vesicle to form the ejaculatory duct, which traverses the prostate and empties into the urethra. Secretions from the vasa deferentia, the seminal vesicles, and the prostate all contribute to the seminal fluid. Within the scrotum, each vas is closely associated with blood vessels, nerves, and muscle fibers. These structures make up the spermatic cord. Because hernias are relatively common, it is important to understand the anatomy of the groin. The basic landmarks are the anterior superior iliac spine, the pubic tubercle, and the inguinal ligament that runs between them. The inguinal canal lies above and parallel to the inguinal ligament. It forms a tunnel for the vas deferens as it passes through the abdominal muscles. The exterior opening of the tunnel, the external inguinal ring, is palpable just above and lateral to the pubic tubercle. The femoral canal lies below the inguinal ligament and medial to the femoral artery and vein, somewhat perpendicular to the inguinal ligament. A hernia that bulges forward from just behind the external inguinal ring close to the pubic tubercle is called a direct inguinal hernia. A hernia that lies above the inguinal ligament near its midpoint, the internal inguinal ring, is an indirect inguinal hernia. It may enter the scrotum. A hernia that is palpable adjacent to the femoral artery and vein in the femoral canal is a femoral hernia. After comprehensive hand hygiene, and with the patient's health history in mind, you are now ready to examine the male genitalia and check for hernias. During examinations of a sensitive nature, including those of male or female genitalia and of female breasts, it is important to observe the requirements of your facility pertaining to liability and confidentiality. Therefore, clinicians should often be assisted by chaperones, such as a nurse or other health provider, during all such examinations.
I'm going to examine your genital area, so if you can please stand down for me and lower your briefs.
Okay.
The male genitalia may be examined with the patient standing or supine. The standing position allows better detection of hernias or a varicocele. Wear gloves throughout. From a seated position, expose the standing patient's genitalia. In adolescent patients, assess sexual maturity by noting the distribution of pubic hair, the size and shape of the penis and testes, and the color and texture of the scrotal skin. Later, you will palpate to determine testicular size. Check the skin and pubic hair around the base of the penis for inflammation, excoriations, or lice. If present, retract the foreskin, also called the prepuce. Smegma, a cheesy whitish material, may accumulate normally under the foreskin. Also, note any chancres and carcinomas. Inspect the glands, noting any lesions or scars, and observe the location of the urethral meatus, normally at the tip of the glands. Compress the glands gently between your thumb and index finger to open the urethral meatus. Inspect it for discharge. If any is present, note the color and culture it by methods used at your clinical site. If the patient has reported a discharge that you cannot see, ask the patient to strip or milk the shaft of the penis, which may expel some discharge. Have a glass slide and culture materials ready. Next, palpate the shaft of the penis, noting any induration or tenderness. There should be none. Note, palpation of the shaft may be omitted in a young, asymptomatic male.
I'm going to examine the scrotum now.
Okay.
Lift up the scrotum so that you can see its posterior surface. Inspect the skin of the scrotum for rashes or nodules. You may find dome-shaped white or yellow nodules called epidermoid cysts. These are common and benign. Observe the contours of the scrotum, noting any swelling, lumps, or veins. With your thumb and first two fingers, gently palpate each testis to assess its size and consistency and to detect any nodules or masses. Testes are normally smooth, ovoid, symmetrical in size and consistency, and sensitive to pressure. Locate the epididymis on the superior posterior surface of each testicle. It feels nodular and cord-like and should not be confused with an abnormal lump. Using your thumb and fingers, palpate each spermatic cord, including the vas deferens, from the epididymis to the external inguinal ring. Note any nodules or swellings. Abnormal swelling in the testicles can be evaluated by transillumination. Darken the room and shine a strong light behind the scrotum through the mass. Look for transmission of the light as a red glow.
I'm going to check for signs of hernia now.
Okay.
With the patient standing, assess for hernias. inspecting the areas of the external inguinal ring and the femoral canal for bulges. Continue to watch as the patient bears down.
Please bear down as if you're having a bowel movement for me, please.
If no bulges are observed, palpate for an inguinal hernia. Place the tip of your right index finger close to the inferior margin of the scrotal sac. Then move your finger upward along the inguinal canal, invaginating the scrotum. Follow the spermatic cord up to the external inguinal ring just above and lateral to the pubic tubercle.
Bear down for me, please.
Ask the patient to bear down and search for any bulges or masses that touch your finger.
Okay, good.
Now palpate for a femoral hernia by placing your fingers on the anterior thigh in the region of the femoral canal. Ask the patient to bear down again or cough. Note any swelling or tenderness.
Now cough for me, please.
Repeat inspection and palpation on the left side using your left index finger to palpate the external and internal inguinal rings. If you find a large scrotal mass and suspect that it may be a hernia, ask the patient to lie down. The mass may return to the abdomen by itself. If so, it is a hernia. If not, assess whether you can get your fingers above the mass in the scrotum. Listen to the mass with a stethoscope for bowel sounds, as bowel sounds may be heard over a hernia, but not over a hydrocele. If your findings suggest a hernia, gently try to return it to the abdominal cavity, but do not attempt if the mass is tender or if the patient reports nausea and vomiting. This examination may be an opportune time to instruct the patient on the technique for testicular self-examination, which is best performed after a warm bath or shower. Before examining the rectum, let's review its related structures. The anal canal is the terminal segment of the colon. Above it, the rectum balloons out and curves posteriorly. The anal canal, unlike the rectum, is sensitive to pain. In men, the prostate gland lies at the base of the bladder and surrounds the urethra. The posterior surface of the prostate can be felt through the rectal wall. The two lateral lobes of the prostate are separated by a shallow median sulcus. The anterior lobe cannot be palpated. The seminal vesicles above are not usually palpable. Common or concerning symptoms relating to the rectum, prostate, and bladder include a change in bowel habits, blood in the stool, pain with defecation, rectal bleeding or tenderness, anal warts or fissures, a weak stream of urine, and burning with urination. When acquiring the medical history, be sure to ask about any personal or family history of prostate cancer, colonic polyps, or colorectal cancer. After the age of 50, the risk of prostate cancer increases sharply for men, especially African Americans. So familiarize yourself with the latest screening guidelines from major organizations in order to counsel your male patients about the benefits and risks. You may need to provide counseling about the risk of sexually transmitted infections from anal intercourse.
I'm going to do a rectal exam now. Can you please turn on your left side for me, please?
For most purposes, the side-lying position is satisfactory. Position the patient on his left side close to the edge of the table and drape the patient appropriately. With a calm demeanor, explain each step of the examination, instructing the patient in what to do and detailing what the patient may feel.
Please lift your right leg and bend your right knee for me, please.
The patient's right leg should be flexed at the hip and knee for stabilization and good visibility. Adjust the lighting for a good view of the anus and surrounding area. With gloved hands, spread the buttocks apart and inspect the sacrococcygeal and perianal areas for lumps, ulcers, inflammation, rashes, or excoriations. palpate any abnormal areas, noting any lumps or tenderness.
Can you bear down, please, as if you're having a bowel movement?
Ask the patient to bear down as you inspect the anus for hemorrhoids, fissures, or other lesions. Now lubricate your index finger and advise the patient that you are going to put a finger into his rectum.
I'm going to examine the rectum by inserting my finger and probing inside. Okay. Please try to relax, but at the same time bear down.
Ask the patient to bear down and place the pad of your index finger over the anus.
Bear down for me, please. Relax.
As the sphincter relaxes, gently insert your fingertip into the anal canal, pointing toward the umbilicus. Note sphincter tone, tenderness, induration, irregularities, or nodules. Occasionally, severe tenderness prevents entry and internal examination. Do not try to force it. If you can proceed, palpate as much of the rectal wall as possible. Insert your finger fully and rotate your hand clockwise as far as possible, then counterclockwise. Note any nodules, irregularities, induration, or undue tenderness. To bring a possible lesion into reach, take your finger off the rectal surface and ask the patient to bear down again.
Will you bear down for me again, please?
With your hand still in a full counterclockwise position, slide your finger over the posterior surface of the prostate gland, noting its size, shape, and consistency. By turning your body somewhat away from the patient, you can feel this area more easily. Identify the lateral lobes, median sulcus between them, and any hard areas, nodules, or tenderness. If possible, extend your finger above the prostate to the region of the seminal vesicles and the peritoneal cavity, and sweep the anterior wall, noting any nodules or tenderness. Return your hand to a neutral position and gently withdraw your finger. Remove your gloves, then wipe the patient's anus to remove any lubricant, or give the patient tissues to do so himself. If fecal matter is present, note the color and consider testing for occult blood. It may be easier to examine the anus, rectum, and prostate while the patient is standing. To do this, have the patient lean forward, resting his upper body on the examining table. Proceed as previously explained. For female patients, the rectum is usually examined after the female genitalia, while the woman is in the lithotomy position. If you need only to examine the rectum, the lateral position is satisfactory. A clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care.
Genitalia, circumcised male, no penile discharge or lesions, no scrotal swelling or discoloration, testes descending bilaterally, smooth without masses.
After practice and further review of this video, make sure you have mastered the important learning objectives for examining the male genitalia, hernias, anus, and rectum.